Hi everyone, and welcome to another Voices Sociology of Media for 2022. Today, we are very privileged to have someone who is doing a lot of innovative work in the area of what I would say brain science. And that is a clinical psychologist by the name of Benjamin Shields. And I'm just going to read you a little bit out Ben's background. So Ben is experiencing in cognitive behavioral therapy, acceptance commitment therapy, trauma-focused therapies, which interrelates to cognitive processing therapy and narrative exposure therapy, counseling, neurofeedback for the treatment of depressive anxiety, obsessive compulsive, and trauma stress-related disorders. He is currently doing a PhD at Swinburne University's Brain and Psychological Science Research Centre, and he's researching several brain networks related to post-traumatic stress disorder and neurofeedback as an adjustment treatment to cognitive processing therapy for post-traumatic stress disorder. Wow. Ben, can you tell us a little bit about yourself and also perhaps break that down to what does that mean?
Yeah, it's quite a lot in one package like that. In terms of breaking it down, maybe a little bit about sort of how I came to
Yes, that'd be great.
that study. As a psychologist, you're going through, you kind of do your undergrad, postgrad, and masters, and you learn about the treatments, the evidence-based treatments for conditions such as depression, different sorts of anxiety, and post-traumatic stress disorder, among all the others. But the focus is really on diagnosis and the evidence-based treatment that's used for that diagnosis. But there isn't so much of a focus on sort of what's happening behind the scenes in terms of the nervous system. There isn't so much of a focus on the journey to the diagnosis. For example, somebody may present with depression, but the depression may be secondary to another problem. For example, if someone may be experiencing really persistent worry about things, a pattern of generalized anxiety that has been exhausting, that it can fronts them with images of really terrible outcomes about the future. That experience of that condition is really depressing, and because of the exhaustion factor and what the person's exposed to in their inner world, their inner world is kind of plagued with terrible outcomes. They can experience a depression secondary to what's happening underneath. And in terms of the diagnosis might pick up the depression, but it doesn't necessarily pick up the underlying pattern. And even where that's come from for the person, where did the person learn that pattern of worrying about the future? Where was it modeled from? And how did those cycles kind of pick up for them? And what factors underneath in the nervous system perpetuate those sort of loops? And so working with these, working with the front end, using evidence-based treatments for those types of conditions, it's really hard not to think about what's going on underneath. And that was a driver for me in terms of wanting to do more research myself, which then sort of pushed me into a situation where I was thinking about doing the PhD to really immerse myself in that area. But really, I guess the main drive is to look at what processes underpin different conditions, how they overlap, how people got to those conditions, and are there different ways of breaking conditions down, breaking treatments down, and augmenting them with different sorts of therapeutic approaches to help either support the treatments that we have to use, or maybe the standalone treatments that actually help, that can help someone to heal from things or make changes to what they're experiencing.
And with your work, how does medical, or say, using medications as a tool to support that process. Where do you see the role of that in terms of the healing process?
Yeah, it's a good question because in our field, there's been a bit of a journey in terms of our approach. And when I was doing my undergrad, we had a different DSM, Diagnostic Statistical Manual. It was a different sort of conceptualization of things, in that sort of mid-90s. And in the last 20 years, we've had sort of the advent of sort of brain imaging, sort of MRI, and understanding what's happening in the brain. So we've kind of gone from a model where we thought the brain was more static, that it couldn't really change. And so the focus was on brain chemistry and sort of changing, introducing different medicines to change how the nervous system was working. But since since the last 20 years, we understand that the brain is a lot more plastic in how it responds to things in ways that are adaptive and ways that can create problems for people. So the medications we use, a lot of them have come about at a time, in a period in our understanding of the nervous system and psychology where we didn't understand the plasticity of the brain as well. So we probably are still operating on some assumptions about medications. And in that same camp, there's a lot of medications we don't really understand what the mechanism behind them is. So that it introduces people to a process that involves a lot of trial and error. So people will go and test out different medications, and they find that they don't respond to them or respond well to them, or they have side effects that are particularly difficult. So, and often there's a ramping up and then a weaning off. So that process can be really, really tiring, confusing for people. And there's not necessarily much we can do about that, because in a lot of cases, we don't really know how people will respond to medications until they're trying them and testing them out. And sometimes that's at a very vulnerable period in their life where they're doing those trials of the medications. But in terms of the effectiveness of medications and the application of them, for different conditions, they do have a role, and we can look at their role in terms of bottom-up processes. So say, maybe I'll give you an example in terms of a different presentation. So say, for example, if their primary thing is like depression, so really, really low mood, so their sort of lens on the world is one of hopelessness. They look into the future and it looks really bleak. There's a really low energy and lethargy. Arousal is incredibly low. So there's not enough arousal in the nervous system even there's not enough arousal such that the brain is able to filter information. So people can end up in particular cognitive loops, rumination, worry. That people in that sort of situation can often withdraw from everybody as well. So they become sort of cocooned in their inner world, but also in their physical world as well, separated off. And they can often be very tearful, very emotional. And in that situation, even from what I've described, there are some processes that go from the mind that has an effect on mood. So it's kind of like what's playing in the person's mind. For example, if they are thinking about, which often is the case for people who have a really low mood, their mind will present to them a catalogue of all the perceived failings from the past, for example, all the times where they feel like they've failed. And what's projected into the mind as well is an image of the future that is absent of any joy. When they are out in the world, they look at things that might otherwise kind of create a sense of joy, but they don't. And that can be really alarming for the depressed person.
I was just going to ask you on that point, and as you're speaking, I kept relaying it back to our current situation with the COVID pandemic. And I guess I was looking at the therapies that you subscribe to and are committed to. How does that play out at the current with people at the moment, and patients that you might be seeing or clients that you might see, in terms of that the threat is real, like in the environment, that people have that potential to die from the condition, but that it becomes, at what point is something a normal response versus and I guess a hypered over something that's just not really realistic, but you're consumed by that sense that you're going to get it. So how does that play out?
Yeah, it's a really good question, because like COVID and the experience of shutdowns has had all different sorts of impact on people. So and from the perspective of therapists, you can see how it has aggravated and amplified, in many cases, what's already there. So say, for example, if someone had a tendency to worry more and has sort of more health anxiety, which I think you're sort of pointing to, that can really be aggravated. And so what the person experiences then is, they will often sort of imagine getting it and what might happen, and it's sort of catastrophic thinking in that way. And, we have a range of different ways of helping people with that. A lot of that is cognitive behavior therapy, thinking things through, looking at evidence for things. But in another way, many of the things we do as therapists rely on people's connectivity with other people and in the physical world. And a lot of those things have really been knocked out, like during shutdowns. So cognitive behavior therapy, like, it involves people engaging in different behaviors. If we want to do, say, for example, if someone has had something traumatic happening, we're doing exposure work that would require them to be out in the world. And suddenly that arm of therapy is no longer available.
I was quite interested in, and I think our listeners might be interested in, if you can just a bit of it to explain us, narrative exposure therapy.
Narrative exposure therapy, yes. So narrative exposure therapy belongs in the trauma therapies kind of family. So, so if we look at therapies that relate to trauma, there's a variety of different parts that make that up, and those parts relate directly to how the nervous system responds to more extreme stresses. So maybe I can give you an example about how the different how those components are sort of encoded in the nervous system and become part of the trauma experience. So I'll give you a lived, not my lived experience, but an experience of some. I'll give you a traumatic experience example. So say, for example, if somebody were in a terrible car accident that was life-threatening. So say, for example, they were driving along sort of in a remote location, and they slid off the road and their car smashed into a tree, for example. There's a certain, the nervous system in that environment, the arousal peaks in that situation because it automatically detects that there's a life and death. It's a life and death situation. And that happens automatically. So we don't have to consciously turn the nervous system on for it to recognize that we're in a life and death situation. We have that ancient wiring built into the core of our nervous system. So what happens is, in terms of perception and memory, the encoding of memory becomes really dense. So you can kind of think about all your memories of the past. They tend to be when arousal is higher. And by arousal, I don't just mean sexual arousal, arousal in the nervous system when there's more excitement. So we tend to think about, if we think about our memories of childhood, of early adulthood, or even, recent memories, they tend to be when when we're happy, when we're feeling really joyful. Like we'll have holiday memories, you know what I mean? Where and that's because there's an excitement there that it puts the nervous system in a different mode. We'll remember when we've been in the grip of grief or loss. You know, we'll have really searing memories of horrible experiences. We'll remember sexual experiences. We'll remember experiences of great meals we've had, and that's because in certain instances, when arousal becomes higher in the nervous system, there's a encoding of sensory information, things we're remembering. You know, we might remember if I think about being on the Amalfi Coast, and you still remember the meal that you were having there, and maybe the feeling of the air and what things you were looking at. But if you're thinking about what you were doing last week, you can't recall it because there was nothing to mark that in terms of the nervous system wasn't in a mode which was about encoding that because it wasn't important to survival. So say back to the example of, the car hurtling off the road and smashing into a tree. Arousal peaks into the fight or flight mode. So there might be a song playing on the radio in the car as we're doing that. That song will become imprinted onto that experience such that even in years to come, we might hear that song and it'll take us straight back to being in that situation. We might recognize that we're in the car in that situation where it stopped moving, and then we will have there might be the smell of burning plastic or other smells around, and then we might have a thought that is, this car could catch fire and I could die here. But when we have that thought, then we respond emotionally to that thought with a sense of horror and intense dread. So it leaves a sequence of events, some of which were in the physical world, like the accident, the actual dynamics of the accident, but some of the stresses in that situation were also internal, they were thoughts about it. And also what we've encoded visually, like what we're seeing, what we're hearing, what we're touching, how we're feeling in the body, and also thoughts. All of that information becomes encoded in a much richer and more dense way. And these pieces, these sensory, these narrative pieces, visual-spatial pieces become mapped together and they sink down into the long-term memory store. So that later in life, when we might encounter the smell of burning plastic, we might encounter the song that was playing, or one element of that, and suddenly it pulls up from the long-term memory store like a spider's web, these other sensory or perceptual like little pieces, and we end up experiencing them again. And with trauma, sometimes that retrieval process can be really horrifying because it'll pull up pieces that are trauma related and incredibly distressing. Does that make sense?
Oh, that's incredible. And I was hearing that and I was thinking of my life, and I always try, and it's like, for me, like being someone who is part of the stolen generation, I have thoughts, and I remembered like I have little segments, and one is that I remember running away from my adopted family when I was 3 or 4. How bizarre is that? I just remember that feeling of trying to get away, and it's saying to that, because I wasn't told I was adopted to many years, saying, and I don't know how it came from, "You're not my mum." And I remember as a child, as 3 or 4, apparently I was screaming a lot about a strange woman taking me. And, I just thought I was mad, although I was told, "No, you're silly, you're imagining." But obviously this just is an example. And again, for other people who've been from the stolen generation, that these memories are so become embedded. And I wonder, I was going to ask you, is it a way for us to heal, to relive them in a safe space? Like, so for myself, this happened, I'm 53. So, your mind, your connect in your body. There's a time and a space when you can relive that. And does that heal that memory? Like, does that, through reliving it in a safe space with a therapist, can that actually heal that?
Yeah. Yeah. Well, I mean, firstly, yeah, I mean, I'm sorry you've had that experience. You know, for a young person to be having that experience is bad enough, but without the context, you know, there's no compassionate context.
No, yeah.
So that's another aspect there of that trauma, you know, to not understand why we're feeling the way we are. There's no comfort there to explain. And it's one thing to go through something harrowing and incredibly difficult, and we have a context, there's a reason we understand. So the confusion around that, I really feel for you, because that's another aspect of that.
Ben, when you speak, and I'm sharing with the listeners, it helps me for the first time in my life hearing you, because one of the things I'll share with everyone, apparently as a young child, I had a fear of sleeping on my own. And I was screaming in my cot. I have a remember of hands taking me. And I remembered I had this till early adolescence that I could not sleep on my own because I feared I was going to be taken away. And this kind of explains to me and to everyone listening that we can make connections sometimes later in life. But at that time, it didn't make sense to me, because all I thought it was just darkness that I feel. But what it was, perhaps it was my body and my mind coping with the fact that I was taken away from another space, you know, and I was an infant, like 6 months old, and somehow the brains tried to process it in my little baby mind what had happened. So this is so incredible, Ben, that you've enlightened me on how the brain is it like the coping mechanism that helps us.
It's encoded it perfectly well. I mean, for an infant doesn't, you know, we have memories, we encode things before we're able to articulate it, because, you know, infants, we don't have those sort of modules for being able to do that. But we have something that we can explain as being a working model. So there's like a model for something, for example, being taken away from our attachment figure. That is a model that's hard to articulate. Do you know, where is that? It's not necessarily visual. Is it physical? I'm not sure, but it's kind of this concept. It's like a concept. And when we become adults, we can still be experiencing these sort of working models. For example, a working model might be where, you know, part of us really yearns for closeness with somebody, but there's another part of me that feels angry about that, or I don't want to do that. I feel angry at the other person, but part of me also yearns to be close. So we have these competing parts of us, and parts work. There's a lot of therapies that are working on sort of self states like parts, and the self being the aspect that's observing that. Like, I'm observing, part of me yearns to be close. Another part of me feels angry and wants to push that other potential attachment figure away. I'm the observer. I'm observing these different parts. You can't be the observer and the thing at the same time. So what are these models? And I think some of these models, and research will show us too, that those models can come from our infancy. Our relationship with the attachment figure and the dynamics in that relationship play out in adulthood.
And that's such a one. Hearing this, and I'm sharing with everyone as well, that I was diagnosed with complex attachment disorder. So I'm sharing it, and now it all makes sense to me, because it was never explained to me like this, Ben, and never explored. And I guess part of it because I never shared the fact that I was adopted and I had these memories, because for a long time when I was growing up, I thought I was crazy. You know, I was imagining. I was told I was imagining, and I remember screaming and hearing voice, you know, but it was the faces, dark faces. And now it sort of makes sense to me when you're saying all this, that it was my way of coping with something that it was trauma, if we want to call it that word, that was happening. And physiologically, I was responding to that, perhaps, as you said, the fight and flight mode very early on. as an infant for survival. And it's incredible when you hear that. And when someone like
Mm,
yourself helps conceptualize it, it does
mm,
have a sense of like, oh, this is why in my adult relationships, I've gone
mm-hmm,
this path. So
mm-hmm.
going on with what you're saying and your therapy, and perhaps people listening that they might have issues with perhaps something that happened earlier on, is
Yeah.
there a point within therapy, I guess, like a cathartic moment or something, when all of a sudden, I don't know if it's the dopamine to say, this makes sense. It's like, like a
Mm-hmm.
jigsaw puzzle. Like I'm
Yes, I
thinking in
do.
my mind, and all of a sudden, what you've done, it's like for me, certain things have now connected of
Mm-hmm.
my experience.
Yes. Yeah, I understand. Well, I mean, from what you've explained as well, there was a sense that there was something wrong with you,
Mm,
for having those experiences. So even the context actually then provides an explanation for that part. So there may be a feeling of sort of shame that has become
mm,
tangled up or layered around that experience. So say, for example, if we're working through that, we might discover that there's an interpretation of what's happened that is about the client that they can be liberated from or unburdened by. That there was that situation was confusing for the child,
mm,
but the burden of that confusion wasn't theirs. You didn't do anything wrong. There was nothing wrong with your response to what happened. It's because there wasn't a context provided, and the context, even if that explanation had been provided,
mm,
it it wouldn't have helped anyway, because it shouldn't have happened. And that context is important as adults for us to understand. So we call them in cognitive processing therapy, they're stuck points. It's kind of like they're the interpretation of what's happened. And often they can become associated with shame. People become that sense of implication people have in their original trauma, but also in their response to it. And sometimes how the adaptations, how they affect their adult relationships, how they affect their functioning in the world. There can be shame attached to that. People might
mm,
not trust parts of themselves.
mm,
Do you know what I mean? So understanding where those parts came from in terms of, were they adaptive responses? Did they help me to survive? Even things that might seem that we might really even hate about ourselves. The fact we might not even let people close, or we might be with people who really want to please everyone around us, always have to be there for others at the expense
mm,
of our own mental health. These parts might have played a role in our survival and functioning early on. And to understand the origin of those parts of us is really quite helpful, because rather than hating on them, we can actually we can recognize them for their service.
mm.
And as we develop a stronger sense of self, we're able to to unburden them from their role. And these concepts I'm talking about now, they belong in internal family systems therapy. So if people are interested in
Mhm.
sort of that perspective on things, the foundation of self, and then adaptive self states and parts, and how to recognize the development of those parts and unburdening parts as we develop a strong sense of self, that they can look up internal family systems therapy. And Richard Schwartz is the author of that. And that's it's a very respectful and compassionate sort of therapeutic approach.
Oh, it's just here, and it's like, I don't know if other people are listening to this, but for me, it's like light bulbs going off in my head. And I didn't realize, and I wasn't going to share this with you, Ben. It just happened naturally. And it shows you the
Good.
skill you are of a clinician, that through this like the talk therapy could really come through. And going on with this, I'm just curious now, with your PhD, your study, is there, what are you hoping to find in terms of
Mm-hmm.
the way the brain operates? Is there a
Yeah.
point to which are you hoping to find exactly at what point a thought becomes, how do I say it? A thought is triggered by a subconscious or
like
response.
some other process.
Is that sort of where you're heading in terms of understanding where do thoughts come from, and are they related to, because obviously I'm hearing as though past events are important and experiences, and
absolutely,
is it that in case it does shape us? Like from my own experience, does that mean because of what has happened, my brain, in the way I guess new information comes, it kind of becomes a kind of like a protective way or a certain way I look at the world? Hope that makes sense.
Okay. It does. It does. And in terms of the research, you could think that we have a lot of research about how like memory systems work. So, you know, the example I gave you, the car accident,
yes,
you know,
exactly.
like later on. Well, it's like, you know, it's like when I go to I've still got a Nana, you know, she's 91, and she has a particular smell in her towels. I don't know, like it's a fabric softness.
Yes.
You know, but even me bringing up the concept of that will potentially trigger a similar thing for you or for other people listening to that. It's the mind is like it's almost like a Google search or a YouTube search. You put an idea in there, and then your mind will automatically populate itself with similar concepts. If I said to you, you know, think about an awesome holiday memory again, your mind will produce a catalog of different memories that you can't control. You can't decide what pops into that visual space in your mind, because there's processes that happen before you're consciously aware of things. And that is evidence that we have an automatic mind. And the automatic mind that belongs in a brain network called the default mode network. It's a part of our mind that simulates things that are going to happen. It goes back and replays. It's a mental time machine. So you can go back in time, you can go forwards in time through imagining. You can imagine all sorts of fantastic stuff. So it's unlimited special effects budget in this part of your mind. And that's where our inner life is. And that is something that is, it's hardware based. It's something that we can test in the brain. It's like an internal screen. It's like a movie screen in the mind. And when people are doing like mindfulness practice, for example, which is sort of one of the core parts of acceptance commitment therapy, and other things sort of now in the last kind of 10 or 15 years, it's become more of a thing, observing thoughts that come into the mind. So when we're observing thoughts in the mind, you know, as you're doing before when you were sort of became aware that thoughts were coming into your mind, because I was bringing forth different concepts. That was actually, that's actually a dance between two brain networks that's involved in that happening. So you have a central executive network that connects to this automatic default mode network. So when, you know, you might be wandering around your home, lost in thoughts, daydreaming about
all the time
about things. It's where we spend probably about half of our time daydreaming, thinking about stuff. But and you may suddenly become conscious. It's like, oh, I've been thinking about this. You know, maybe I've been practicing a discussion that I want to have with someone that's difficult, for example, and you might realize you've been thinking about that for an hour, and you might recognize that it's had an effect on your body. Because so say if you're thinking about something that creates tension or it's uncomfortable, you might realize I've been playing this in my mind, and now I'm all tense or I'm grumpy or snippy. So that's evidence that there's processes that happen automatically that we can then become aware of. And that's called metacognition, which is sort of an awareness of what the content of the mind is. And therapy helps us to train metacognition. So being more aware of what's playing in the mind, but also accepting that what plays in the mind is automatic and we can't control it. and being more okay with that. So when we have that, it's like a top-down regulation. So like we have our wisest mind that's able to observe automatic thoughts. And that's really where the self is. The self is in the central executive observer of a mind that is primarily automatic. If our mood drops, for example, this is where it gets interesting, because say if you go through a period of depression and your mood is really low, that actually affects what contents, the nature of what comes into your automatic mind. So say like if you imagine a TV screen that's in your brain, it's constantly playing stuff. If we're depressed, it tends to play things that are more negative, more sad. The themes are more hopeless. It's kind of like drifting into the sad movie genre, as opposed to being, more neutral drama or the comedy section. And that processing we can't control. So a depressed person in therapies sometimes will say, I wish I could stop my mind from doing this. I know that the future probably isn't as bleak as my mind would, as what's playing in my mind would have it. Or the person who tends to worry about terrible outcomes or catastrophic type thoughts, they might understand that, that might be irrational, that the things they're focusing on, there might be 0.005% chance of happening. And it's like, why can't I stop my mind from doing this? That's like this, the self part, the central executive referring to what's playing in the automatic mind. And sometimes we've learned to do that early on in life. If we've lived in environments where arousal's been high constantly, it's very high stress, the nervous system's learned to look out for threats. There's a threat bias there that's become kind of embedded in those processes. And that can form a little loop then. If we've come from a living environment as children, that there was a lot of tension, and then our minds tend to then produce, we imagine threats in our close relationships. We can become more skeptical about people, more close to people. We imagine terrible outcomes in relationships or other things in our life. And because that's constantly playing in the screen in the mind, our body responds to that with tension and high arousal. And because the body's in that state, then it creates this attentional bias that then produces more thoughts that are of a similar nature. So we end up caught in this loop between what's playing in the mind and how the body's responding. And these are attentional biases. So in therapy, what we want to do is increase an awareness of that, but then interrupt that pattern as well. And we can do that via a range of processes that sit underneath therapy, like improving someone's conscious awareness of what's playing in their mind. Sometimes as well, like I've seen a lot of things where it's like, my therapist just told me to go for a walk, and I paid $200 for that advice. And it's so simple, patronizing. And it can be patronizing if people are not given the context. But it's that if a person becomes so consumed by what's playing in their mind. So say like if someone is constantly imagining terrible outcomes in the future, them going and doing different things during the day, like your mind, that screen in your mind, it's like one of those old computers from, the year 2005 that plays like a screensaver of what's in the pictures folder. And that screen tends to do that. Whatever content was being playing will just continue cycling around. So there's what I call like a dilution method, where we can, if you introduce more activity, that's why therapists often try to get people to get out and do different things, so that when we shut our eyes at the end of the day, there's an introduction of different imagery even in the mind. We can even train the brain to think about different things so that that content is diluted, and therefore even training, sometimes with worry, we can introduce things where you're getting people to consciously think about stuff that has an arousal bias that's sort of quite neutral. So it's interesting, but it's not it's not boring, it's not overstimulating, but it's kind of compelling enough to get people to do it so that the body can settle. It's like giving the body a break from its exposure to terrible or catastrophic thoughts. Does that make sense?
Oh, it's wonderful. And I'm going to say it's been such a wonderful journey. I know for myself, and I hope people listening, that your insight into understanding some of the issues of adjustment and the self. And I know for me, I've learned a lot about it. And just as we're finally finishing up, if people were interested to connect with you, Ben, in terms of your work, how can people reach you?
They can have a look at my practice website if they like, which
Yep.
is we have I have some colleagues there who we have a similar kind of approach to therapy work and conceptualizing this type of stuff. We have a similar way of working, so they can have a look at my website. There's a lot of research. Different books that can help people that are written in ways that are really, easily consumed by people who are not neuroscientists, because a lot of the research, it's very, very hard to understand for me too, being a clinical side.
Well, Ben, you've really explained a lot of the concepts in everyday language. And for me, being a visual person, it's really helped me connect to a lot of past events. And as I was saying earlier on, I hadn't thought of sharing any of this, but it just shows everybody out there that finding a really good clinician that you can connect with is probably the tool. If you are feeling anxious out there with COVID, or you feel as though you're not coping, or your brain is overstimulating or reacting, let's consider a good clinician. So thank you so much for your time, Ben. And we hope we can have you again about different topics, because I feel there is such a flow on that we can let information out for people. So as I said, everyone, please take advantage of Medicare at the moment to have access to see a clinical psychologist, because it really can help you in these times of trauma or pandemics that we feel as though we have no control. How do we get ourselves to having a sense of control of what we do? Thank you for your time.
My pleasure. Great to meet you.